Hello everyone, this is Dr. Alex Vasquez with video number 3 on our upcoming International Conference on Human Nutrition and Functional Medicine. This, of course, will be held here in beautiful Portland, Oregon, September 25th through the 29th. A couple of days ago on our Facebook page, I posted a challenge case about the initial laboratory evaluation of a patient with chronic musculoskeletal pain and inflammation. That challenge case actually stems from my own clinical experience and the application of the concept about asking better questions to get better results. So back in 1994, in a program called Advancement in Clinical Nutrition, Dr. Bland said the questions we ask determine the answers we get. So I'd like to honor him for putting out the idea that we need to ask better questions in order to get better and more accurate clinical results. Let me show you what I mean by that as we go through this case report. Many of you, of course, have already registered for our upcoming conference. You've got a couple of ways to do that, and I encourage you to go ahead and register while we still have the early bird registration discount available. You can register online, that's our first option. Second option would be to fill out our registration form and just send a check. Third option is you can correspond with us by email and phone, and we'll help process your registration right then. We have a set of notes that will be available soon. All you have to do is cover the cost of the shipping and the printing, and these will be available to you at a very, very reasonable price for those of you who want to get a head start on the material. So basically, what many of you are going to experience in the conference is not only new information, but also a new process of thought. And so to get that all of a sudden can be a bit overwhelming. So I'm trying to help you have a head start on the material by providing this set of pre-conference notes. And again, it'll be available to you at printing and shipping costs, and it's actually very inexpensive, probably around $5 or $6. In September, we will meet here in Portland, Oregon. Here's the Oregon Convention Center, right next to the Willamette River. Most of you, of course, will come in through Portland's International Airport. It's a very nice, award-winning airport with Mount Hood in the background. As you can see, we've got great local food. To the west of us, we have the Oregon coast. To the east of us, we have the Columbia River Gorge, including Multnomah Falls, as you can see here. Very beautiful area. I encourage you to come out a day early or stay a day late and enjoy the region. What I'm going to do right now is talk about some of our conversations that we plan to have on Wednesday. We're going to start the day discussing the history and direction of functional medicine from concept to a new branch of science and academic discipline. What I'm going to review with you right now is at least a small part of what I call the functional inflammology protocol, which helps us decipher and treat disorders of chronic inflammation. Later on the afternoon on Wednesday, Dr. Cintrone and I will talk to you about integrative pharmacology for disorders of chronic pain and inflammation. You'll find that the clinical application here is for migraine headaches, fibromyalgia, rheumatoid arthritis, psoriasis, osteoarthritis, and again, other types of rheumatic diseases. Here's a diagram of the functional medicine matrix that I made back in 2003, and what we're going to do in this conversation is focus on inflammatory musculoskeletal disorders. That's the structural aspect of this previous version of the matrix. So when we look at this from an integrative perspective, we don't simply look at patients with chronic musculoskeletal pain and inflammation and treat them as such. We have to provide them a more thorough assessment and evaluation. We look at hormones, we look at immune and inflammatory imbalances, and of course we look at the gastrointestinal status, as I'll show you here in this example. Recently, I showed you a video on mitochondrial dysfunction and how mitochondrial dysfunction can also promote chronic pain and inflammation. So if you haven't seen that video yet, I certainly encourage you to take a look at it. These mitochondria in all the cells of our body certainly do more than just produce ATP. They also can trigger chronic oxidative stress and chronic muscle pain and chronic inflammation. So I invite you to take a look at that video. It's posted on our Facebook page. It's also on our YouTube channel. It's also on our website. And that'll help give you, again, kind of a conceptual kickstart to the information we're going to discuss on Friday when we have an entire day dedicated to mitochondrial dysfunction, its clinical consequences, and effective treatments. So on our Facebook page recently, I presented this case of a middle-aged man who presents with peripheral polyarthralgia, polyarthritis, fatigue, and an event of definite psoriasis following antimicrobial drug exposure. And I asked, what is your initial assessment and treatment? Now, in order for this video to be postable on Facebook so that everybody can have access to it, I have to complete it within about 20 minutes, and so for that reason I'll have to go through this material pretty quickly. Let's take a quick look at this case. Patients with inflammatory and autoimmune disorders often have multiple hormonal imbalances, multiple metabolic disturbances, and they can often have more than one autoimmune disease at the same time. This is a case of a 34-year-old man who presented for consultation to my office for possible psoriatic arthritis. He had several years of debilitating pain. He had been diagnosed by a dermatologist here in the U.S. with a classic psoriatic flare following use of penicillin for a dental procedure. Two rheumatologists here in the U.S. had been kind of uncertain of the exact diagnosis, but certainly started him on the anti-rheumatic drug protocol that I'll review with you in just a moment. He had been started on prednisone, which of course has numerous side effects, and then he was recommended to start some biologic drugs, the tumor necrosis factor alpha inhibitors. He had seen some doctors in Mexico and had additional evaluations there that we'll review in just a moment. On physical exam, he's got some psoriasis, he's overweight, and also hypertensive. Now, from a medical perspective, we would evaluate this patient with the goal of coming to an accurate diagnosis based on his symptoms and lab tests, and from there we would prescribe the quote-unquote appropriate drug, and then we would just medically manage this guy for decades to come, usually adding more drugs as the previous drugs either become less effective or perhaps have to be replaced due to side effects. So basically what we learn in medical school is that these diseases are complex, but they're idiopathic, and oftentimes it's said that we don't know the cause of these diseases. I would certainly be willing to submit to you and offer to you an alternative to that, which is we actually do understand these diseases quite well based on current research, and we can use that information to leverage better clinical outcomes. So rather than relying on drugs and surgery all the time, let's see if we might be able to gain better insight by asking better questions. When patients present with chronic musculoskeletal pain and inflammation, like psoriatic arthritis or rheumatoid arthritis, they're usually treated with aspirin, nonsteroidal anti-inflammatory drugs, and acetaminophen. From there, they go to prednisone, methotrexate, sulfasalazine, hydroxychloroquine, and the biologics, which are the tumor necrosis factor alpha inhibitors. From there, we can implement some new experimental drugs, or we can try stem cell transplant, but at no point along this course of therapy have we actually addressed the underlying problem. And you'll see that not only is that a rather inefficient way of managing these patients, it's also quite expensive. That regimen would cost at least $50,000 a year for most patients, and it really doesn't work that well. If you look at the study published in Arthritis Research and Therapy in 2012, what they showed is that among patients with rheumatoid arthritis who are treated by board-certified rheumatologists, the average sustained remission over the course of 2 years is only 10%. So let me say that slightly differently. Only 10% of patients treated with optimal medical therapy achieve 2-year remission over the course of 2 years. I think that's very poor performance. Now, here in America, of course, we use a lot of drugs in our so-called healthcare system, and that's why some people say, you know, it's more like a drug care system, because Americans are the most drug society in human existence, and this is quite clear if you look at data from several years ago. However, the trend has only gotten worse. If you look at this article from April of 2013, more than 4 billion prescriptions were written in 2011. That's the most ever. So historically, Americans have been the most drugged society in human existence, and that trend is actually getting worse. Here's another recent quote from an expose that was published in Time magazine. America spends $60 billion per week on what we could call health care or disease care or drug care. Unfortunately, we have a system that's actually incentivized to provide poor outcomes. If you look at the headline of this article from April 2013, patients with surgical complications provide greater hospital profit margins. So the system actually benefits from providing worse care. So let's see if we can explore some options here. So let's use kind of an integrative model to understand that these diseases are complex, but we can understand them. We can apply scientific methods to the assessment and treatment of these conditions, and we don't have to rely on drugs and scalpel for the delivery of health care. So here's the case that we're going to go through. This is a man with kind of an unclear diagnosis, but we can obviously see some psoriasis. He's got years of debilitating joint pain. So let's evaluate this patient beyond simply trying to come up with a clinical diagnosis. Let's see if we can understand what's going on inside to create and perpetuate these immune imbalances. So here's some lab tests that I ran. I told you before that we look at hormonal imbalances, and in this case you can see testosterone is low. He's got some thyroid autoimmunity. So in this case now we've gone from psoriasis, which is considered an autoimmune disease. Now we're seeing evidence of thyroid autoimmunity as well. A little bit of insulin resistance. Thyroid gland is struggling to perform. We'd like to see a TSH below 2, certainly below 3, and this patient's result is 3.5. If we look at the ratio between estradiol and estrogen in this patient, we see that his estrogen is a bit too high and his testosterone is a bit low. Now that creates a pro-inflammatory climate for his immune system, as does the vitamin D deficiency. So when patients are vitamin D deficient, they have higher risk for autoimmune and inflammatory disorders. Clinical trials have actually shown an anti-inflammatory effect of vitamin D supplementation, and in fact it helps to reprogram the immune system in a protocol that I've developed called nutritional immunomodulation. We'll talk about that on Wednesday. More laboratory tests here. I didn't see any evidence of celiac disease. His ferritin's a bit high. I've published quite a bit on iron overload and hemochromatosis, so we're just aware that that's too high, slightly too high I should say, and then we'll address that later after we've gotten some of the other inflammatory markers under control. From the lab tests that he had from his doctors in Mexico, we see that this patient has chronic metabolic acidosis. Dr. Linda Frassetto is going to address that topic on Saturday of our conference and show some of her new research. Some of her research, new articles, was just published last week, so that's pretty much the cutting edge. So beyond metabolic acidosis, what else do we get from this urine test? We also see that he has a lot of bacteria in his genitourinary tract, so he probably has what I call genitourinary dysbiosis as well. From this laboratory test, we see, again, evidence of insulin resistance. Fasting blood tests, we'd like to see the glucose below 85. Anything above 85 is associated with increased risk for cardiovascular death and insulin resistance. So this patient's result came in at 91. And we also notice that his rheumatoid factor is positive. If we combine that with the results here, we see that his CCP antibodies are elevated. And so when we see in patients with chronic musculoskeletal inflammation, when we see elevated rheumatoid factor and elevated CCP antibodies, we call that conjugate seropositivity. What we see here is an immune response against a class of bacteria, or a species of bacteria, called Proteus. Those have been strongly correlated with rheumatoid arthritis and psoriasis. So again, when we ask the right questions, we find new avenues for helping this patient overcome his chronic inflammation. Here I did a stool test and I found that he had Klebsiella pneumoniae in his gastrointestinal tract. Now, if all we had was this result, I think we'd have a hard time saying that this bacteria is of any certain clinical significance. We just note that it's there. Now, Klebsiella pneumoniae in humans is associated with rheumatoid arthritis, psoriasis, and ankylosing spondylitis. So in other words, the pattern there is that we see this bacteria associated with human clinical disease, especially autoimmune rheumatic musculoskeletal disorders. The lab showed no yeast on his yeast culture. However, when we look at the yeast microscopic exam, he's got lots of yeast here. So we call that a negative yeast culture with a positive yeast microscopic exam. Some would say that that's the worst pattern, meaning it's the most clinically significant and the most difficult to treat. Now, let's put all of that in context by looking at this patient's inflammatory and immune response to his gastrointestinal status, including these microbes. So, as I said before, when we just look at the microbes, we don't really understand what that means for this patient. But when we look at these inflammatory markers in context with the patient's history and physical exam and whatever microbes we can find on the culture and microscopic exams, now we can put it in context because we see that he's having a definite inflammatory response within his gastrointestinal tract to these microbes. Now, we could say that it's due to food, but in my experience, a more likely cause is that it's going to be due to these microbes. And oftentimes, when we treat the gastrointestinal microbes, we get a really profound clinical improvement, and that's what we're working towards in this patient. So again, when we look at lysozyme, it's elevated, and now we've got a second marker, lactoferrin, it's also elevated. So we have confirmation of intestinal inflammation We've got evidence of microbial imbalance due to the Klebsiella and the microscopic exam for yeast, and I'm quite certain that this is part of the trigger and underlying perpetuation of this patient's chronic musculoskeletal pain and inflammation. So what we found just by running this test, he's got a little bit of Klebsiella, but he's definitely got yeast. He's got severe inflammation in his gut, and so we can say then that his systemic inflammatory disorders probably have, almost certainly have, a gastrointestinal component. So we can address that clinically and aim to get better results. So the standard medical approach to treating this patient, as you've already seen, is just to diagnose him and then use drugs to suppress the inflammation. But really the inflammation is just a manifestation of underlying imbalance. And from a medical perspective, we'll just add more drugs later. So when he doesn't respond to prednisone, we'll add methotrexate. When that doesn't work, we can add hydroxychloroquine and sulfasalazine. When that doesn't work, we can add biologics. But at no point in time does that approach really address the underlying imbalances which are causing the inflammation to begin with. So the goal there is just what we call medical management. On the other hand, if we use an integrative and a more functional medicine approach, emphasis on fun, then it's actually more engaging for the doctor and the patient. We get to diagnose diseases and assess patients within a context that actually makes sense, rather than just ascribing those diseases to being idiopathic. We can determine the underlying imbalances, as you've started to see here through this initial assessment, and then we can address the causes of the imbalance rather than just treating the inflammation as if the inflammation were causing itself. Inflammatory diseases do not cause themselves. They're sustained and perpetuated by underlying triggers, and so we have to evaluate what triggers might be relevant in a particular patient, and then we treat those appropriately. The goal there, of course, is cure, and that's what we aim for here, not just medical management. So I encourage you to join us on Wednesday when I get to introduce the most recent version of my functional inflammology protocol, and again, we'll apply this to migraines, fibromyalgia, rheumatoid arthritis, and psoriasis. The questions we ask certainly determine the answers that we get. So we're going to show many of you for the first time how to ask the right questions and how to go down a different thought process, a different path, so to speak, so that you can get better clinical results. We're going to do that every day of our conference, and I'm going to help ensure that you get clinical take-home rather than just being deluged with information. I want you to actually know how to apply it. So, of course, we hope that you'll join us for the International Conference on Human Nutrition and Functional Medicine, September 25th through 29th here in Portland, Oregon. You've got a couple avenues that you can use to register, whether it's online, by our registration form with a check, or the third option, which is just to call us and we'll walk you through the process. Again, we'll have the pre-conference notes available soon, and we do look forward to seeing you here in Portland, Oregon. Thank you much.